respected teachers and seniors, respected chairpersons, and dear colleagues. I come from Auckland in New Zealand, and New Zealand is a small country. Yeah, our previous speakers have been from UK and then USA, massive countries. Some of you who work at district general hospitals here would see more patients than we would ever see. This is a map published by one of the reputable institutions during COVID, and they missed out New Zealand on the world map. So that just tells the story of where we are. At the same time, for India, it is not a foreign country because since Kaho Na Pyar Hai, we have had plane loads of Indian visitors coming to New Zealand, and that keeps us, our economy going. And thanks for coming, and please keep coming. All of us take actions every day. We walk into a hospital, we do clinics, then we operate, we do ward rounds, and make decisions. Decisions to treat, investigate, and operate. We are well trained right from our first MBBS to ensure that the action we take is good and for the well-being of the patient. What we lack in training perhaps is to assess our own decisions and the result or an effect of an action that we have taken. And that is where my interest in the outcome measurement started. Overall, the outcome umbrella falls under outcomes assessment, which is where we collect and record all information, and then outcomes management, where using all this information that we have collected very constructively to improve the patient care. What does outcome mean? Outcome means different things to different people. For us as clinicians, it's diagnosis and treatment. Have we done well? For administrators, it's efficiency and utilization. Are you utilizing your theater well? Are you seeing enough patients? For regulators like medical council or royal colleges, it's compliance. And for payers and purchasers, like insurance companies or in setting here, private buyers of healthcare, it's cost containment. Can you make it any cheaper? Bit of history in olden times and more recent one. This is a young lady of 33 years age who was called into the Crimean War to serve the soldiers. We all know her as Florence Nightingale. When she got there, she did outcomes assessment, which showed that mortality was 42.7% of all soldiers admitted. And then she did some outcomes management. She changed the sanitary reforms and it changed the mortality, which reduced to 2.2%. This is the modern take on Dr. Everdis Donabedian's model of structure and process directly proportional to outcomes. His model of care was to deliver a safe, equitable, effective, efficient, patient-centered, and timely care. But it depended on structures, processes, which would equal the outcome. And the structure is hospital buildings, staff, equipment. The process is transactions of patient when they come into an ED, emergency department, and out or clinic, and then out when they are discharged. For instance, if you start someone on gentamicin, the second dose would be trough and hold. You're not going to give second dose until you do the levels and make sure it's safe to do second dose. So that's the process, and it would lead to good outcomes. Every good thing has practical issues like barriers, attitudes to change, and how to do it, why to do it. So I'll take you through some cartoons which are self-explanatory. Why do you study outcomes? Here is a classic example. 95% of us believe that we are in top 5%. Now, there is no room for 95% in top 5%. Therefore, we need to measure them. All of us who have been head of the department would know we have one of these in there. And just because someone is unique, it's not useful. This guy thinks if his hand was stitched to his cap, it would be so much better. If he only knew he does have tools to actually turn it around, or if he observed that the two guys sitting next to him actually are using the same thing and not worried about the sun. And then we are very busy doing what we are doing. We keep pulling our cart with square pegs, and if somebody is offering good wheels, we should take it. We should take time to actually assess what we are doing. And of course, the current climate here and overseas, everywhere it's changing. Consumer protection, their demands, their rights become very important. The league tables in NHS will tell you if you are a colorectal surgeon, what is your 28-day mortality? What is your 1-year mortality? Are you an outlier or are you in the mainstream? So what is important is what to measure. You all would know this key matrix. All the cases we do will fall under these 4 quadrants. If it is high baseline risk and high caseloads, then we should do outcome measures like NEC, esophageal atresia. If it is high caseloads and low baseline risk, then don't worry about outcomes too much. You can do patient-centered outcomes. Low baseline risk, low caseloads, focus on other procedures. That quadrant can be left alone. And if it is low caseload and high baseline risk, then you need to focus on volumes. Can you centralize a service? Like my previous speaker says, high volume centers probably would have better outcomes, not saying low volume centers wouldn't have that. How do you do that? There are several ways, but the way that I'm going to outline is what I found very easy to introduce and carry out, and that is clinical indicators. You can have clinical indicators, registry, surveillance system, patient-reported outcomes, and databases. Please stay away from databases. We are well advanced in that term. Can you do it yourself? Of course you can. So a pediatric surgical department typically has a newborn, an infant, a child, and then urology as a separate subspecialty. So try and figure out one index condition, say esophageal atresia with an anastomotic leak, pyloric stenosis with duodenal perforation, appendicitis as negative appendicectomy rate, hypospadias, fistula, reoperation, whatever you want to select. Make it a clinical indicator, say a leak of esophageal atresia, number of patients divided by total number of patients in your unit, and give them indicator 1, 2, 3. So this is the model I propose. You would have a bullseye, which is green, and you try to be within that. That's the desired outcome. Outside red is time to improve, and in between is progress is needed. And then you plot your clinical indicators in that category. And then you make it a comparative quality indicator pie model. So you decide a threshold that, okay, less than 5% negative appendicectomy rate is perhaps okay. Over 20% is not okay. So hospital 1 will be in red zone, hospital 3 is bullseye, and hospital 2 has room to improve and can come into that. With software engineers in every street corner in India, this is very easy for you guys to develop a dashboard. The dashboard will give you an ongoing dynamic data year after year where you can see your own hospital move and change just when you put your cursor onto that. And I would recommend that this be developed. Take-home messages, weighing a pig does not make it fatter. So just monitoring, then measuring what you do doesn't help improve the quality. You are better off with one good measure, which is common and enough to be reliably measured and actionable target for improvement. Start with one. Do it for your department. Get together consortium of interested departments, hospitals, colleagues. Publish what you are doing. Before you know, more will join, and then it becomes a standard of care. I must acknowledge Dr. Justin Dimmick, who came to New Zealand and vetted our interest in outcomes, and then I visited him in Ann Arbor, Michigan. Our Health Quality and Safety Commission of New Zealand, who designed a dashboard for us, and Royal College of Surgeons, where we did clinical indicators. And I thank you for your attention and inviting me here.